Hello, everyone, and welcome to the Clinics Review Articles podcast. Today, we will be discussing the February 2019 issue of Rheumatic Disease Clinics on best practices and challenges to the practice of rheumatology. I'm Lauren Boyle, the managing editor for Rheumatic Disease Clinics here at Elsevier. Today's podcast will be moderated by our series consulting editor, Dr. Michael Weissman, who is leading the discussion with our issue guest editors, Drs. Daniel Wallace and Swami Venturupalli.
So both of you represent, at least in my view, kind of a divide in the use of electronic assist in healthcare. One of you had to be dragged kicking and screaming into it, and the other really is doing it really from the very beginning. I'd like to see or hear from both of you as to what your opinion is of the future of all these activities, social media, electronic medical records, all the gadgets, virtual reality, smartphones, monitors in the practice of rheumatology. What's the future? Is this going to make a difference? Will there be changes? What do you both think?
I think over the years there has been a complete change with the advent of electronic medical records, which sort of became mandated when the Affordable Care Act passed. There was a period between 2007 and 2015 where many rheumatologists retired because they did not want to learn electronic medical records. I think that all the newer rheumatologists are learning it and picking it up, and many of them are becoming experts and taking it on the road with them and are very much advocates of it. And I think that's a favorable trend. But everybody has their own unique way of viewing all these apps and devices we have. Some prefer to use social media or Facebook or Twitter, or some have a website, others don't, and they're more private. And I think the large menu of options we have gives upcoming budding practitioners many different selections to choose from, which allows them to personalize the type of practice they have.
Yeah. Hey, Michael, thanks for the question. This is Swami. So, you set us up by saying that there might be a generational divide in this adaptation of electronic health records. And I think that's been, noticed in the literature, and it's been written about, and it's certainly been my experience as well. From my personal perspective, and I would consider myself mid-career at this point, I have embraced electronic health records quite a lot, and I actually feel that it has helped my practice of medicine for sure. Particularly being involved in a large healthcare system's electronic health record has been extremely helpful because the transparency that it has afforded all the various specialists that are involved in the care of a patient is quite remarkable. And I find often that doctors like neurosurgeons and other specialists, pulmonologists, etc., all of them having access to the same medical record of the same patient has actually helped in the quality of the care that they receive. Having said that, there are obviously some pitfalls, and you see this cut and paste notes which are often transmitted from person to person, and sometimes if there's one error, it just gets amplified down the road and stays on that chart for a long time. But overall, I think it's not only a positive thing, but I also think it's absolutely necessary, and I think it's good medicine to be able to utilize all the features of an electronic medical record, because it does help keep all the information of a patient in one place and allows a secure way for us to communicate with patients.
Let me give you a perspective of this from a patient. That is me. When I was hospitalized for my spinal surgery, or after the time that I fell and I had a concussion, I had absolutely beautiful, error-free health care. Every doctor knew what was going on with me. it was absolutely perfect. There was no errors in the medication. Everything was done right on time. The problem is I never saw a doctor. No one ever came in to talk to me. At the end of the day, at like 9 o'clock at night, a hospitalist came and summarized everything for me.
It's true. I don't think you can blame the electronic medical record for that. I think that's a systematic problem with all of medicine. And I view electronic medical records as a tool to be used by the system. But if the system itself is not designed in a way to enhance the doctor-patient relationship, I don't think it's the fault of the tool as such, but of the system.
The electronic health records are a nanny. It's a nanny system. It doesn't let you sign off unless you click something. It beeps and whistles if you don't do something right. And you have to document everything in order to get reimbursed. That being said, it is not the job of the electronic health record to retain the personalized aspects of the doctor-patient relationship. That is the responsibility of the teaching institution.
All right, let's move that question forward, Dan. What do you think the changes that need to be made in the relationship between a doctor and his or her patient today when we're faced with these opposing forces that may, in fact, disrupt that relationship? What are the things that you need to tell a young person starting out in practice, whether it's your practice or Swami's or anybody else's, how to maintain that important relationship between a doctor and a patient?
First, you have to make sure that you don't leave the room without doing at least a focused physical examination on the area of interest. That way, the doctor is at least touching you and looking at you most of the time. And this is something the old-time practitioners were very, very good at. It was part of their art. And I think all too often we plug in physical exams when we never even touch the patient. And when also in the in the electronic health record, it puts the amount of time you spend with the patient. And that is now time-stamped in many ways. And you have to be able to do some sort of one-on-one in order to have that timestamp mean something. I think also it has to be part of the educational process. We have to have mentors and people who observe that this is actually being taught.
Yeah, and if I may add to that, I would let a young physician getting into practice or in an academic center, I would emphasize that our job is not to document, but really our job is to take care of patients. So that's number one, and then the documentation is incidental and part of the whole process. And there might be smart ways to become really efficient in documenting, but really that should not be the main area that you spend your time on. You really want to focus in on the patient.
My father, who you knew, was a cardiologist who practiced until 2006, and he learned this gimmick in the 1940s. And that was every time as a cardiologist, every time he saw a patient, he always personally took the blood pressure, because they didn't have them on the wall in those days, and he always did it in both hands. And I still have people who come to me who were my father's patients who say, "Your father was amazing. Do you know he always took the blood pressure in both hands? I always felt twice as good as with anybody else."
All right, so let's expand that a little bit. What are the differences between now and, say, the 1970s when you started, Dan, and Swami when you started 10 or 15 years later, in somebody entering private practice? What are the fundamental differences now compared to the way it was then?
In the 1970s, 80% of doctors went into private practice. Now it's very hard for anybody to go into private practice because the majority are in debt up to $200,000 to $300,000. Often they work as a hospitalist for a year or two first. There are many different opportunities. We have group practices, we have private practices, we have We have niche practices that only take care of a certain specific disorder. There are academic sites. There are there are clinics that are in more than one location. There's very, very large HMOs. There are some rheumatologists that also want to do internal medicine. There's some people that just want to do workers' comp. There are some that are in administrative medicine and that have business degrees. And there's a lot some who wanted to go into basic research. These weren't necessarily obvious to those of us when in the 1970s and when Swami was a neonate. But anyway, I think that, and it's often confusing, and people aren't really mentored on what the pros and cons are of these opportunities.
Well, as you answer this question, Swami, what adjustments need to be made to this new generation of rheumatologists? Now, women, people seeking part-time employment, maybe wanting to work for organizations so they don't have to deal with the difficulties of the business of medicine. What are the adjustments that need to be made for this new generation?
Good point, Michael. I think obviously you've hit the nail on the head. There are adjustments that need to be made. Medicine as a whole it's a moving target in ways that keeps changing on a day-to-day basis. Big organizations have a lot of advantages because they are able to adapt and are able to capture some of the risk involved with the change in the system, and that's the security that they afford the younger practitioners coming out. This issue of rheumatic disease clinics, which Dan and I co-edited with your help, really lays out all the pros and cons of the different practice models, the different settings, including the government setting, the private practice setting, in a very interesting article. Gerald Eisenberg and his colleagues talked about how they created this private clinic and partnered with an orthopedic group and were able to really demonstrate to their orthopedic colleagues that rheumatologists actually could be a good revenue generating part of that practice. We also have academics like Meenakshi Jolly and her team that wrote this really nice article about some of the challenges that academic medicine faces. And as young people come into practice, we are first exposed to our academic mentors, and that seems really exciting as an opportunity. And we've interviewed hundreds of fellows over the last several years, and typically most people say, yeah, I want to be a clinician educator. But the problem is that clinician educator jobs are not really present anymore. So understanding the pluses and minuses of each and every different model that exists out there is important, I think, for a young trainee or young rheumatologist out there. I don't know if we can give you a direct answer. I think it's a personality fit for each individual, and it's important for each individual to know who they are and what they are and where they want to be, and make a personal decision based on what opportunities are out there.
When you both are seeing the new generation of fellows and residents coming through the educational system today, what are some of the challenges that young people are essentially giving you in terms of being able to teach them the proper way to relate to your sources of referral, to relate to patients, develop successful relationships, and so forth? Are you seeing these challenges today in the young people with these preformed ideas about what they want to do? How do you meet those challenges?
A lot of them don't have many ideas. Unlike my generation, I think in my medical school class of 96, 20% had parents who were physicians. That really isn't so much the case anymore. A lot of these are the first person in their family to go to medical school and even attend college. they really don't know the lay of the land. Nobody's really sat down and taught them the landscapes and the opportunities. They come from a wide socioeconomic level. Many their demographics are highly variable. They come from often different parts of the world. We've had fellows from Africa, from North America, South America, Europe, and a lot of these individuals are not going to stay in the environment in which we're training them, which is, for our case, Southern California. They're going to go elsewhere. And so it's it's a highly diverse landscape, and we really it's going to take 6-12 months from first starting to get an even idea what they're good at and what they might want to move forward with.
I think, if I may add to this, yes, there is certainly a lot of diversity, and one way to look at it is that our fellows actually, and I find this true in my own experience, our fellows actually teach me as much as I teach them, and learning about some of these issues from them is interesting for us as we grow in our own ability to mentor some of them. And I think the most important thing, Michael, is that the mentor-mentee relationship is certainly challenging, but as healthcare systems evolve, I think emphasizing that it is absolutely critical in this day and age for time to be allocated and dedicated time to be set aside for fostering these relationships is so critical and so important. And I think, as a system of medicine, we definitely want to encourage this long tradition of mentor-mentee relationships. I've certainly benefited a lot from being mentored by many people, including yourself and Dan, and among others. But I can't emphasize the importance of that relationship in a budding career.
And another comment I'd like to make is that nobody knows what our healthcare environment will be in 10 years. So often it's really hard to prepare to fulfill your aspirations. We don't know if it's going to be government medicine, all private medicine. We have no idea how, the pharmaceutical industry is going to interdigitate with this, how teaching hospitals. We have no idea if it'll be medically viable and solvent. So there's a lot more uncertainty for people in training because they don't know what the future holds. In your time and in my time, we sort of had a pretty good idea that nothing would really change over the first 10 years.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
So we've been talking about people and relationships up to this point. Let me shift the question a little bit, talk about the diseases that we're seeing, because they've changed too. The basic management of patients with rheumatoid arthritis, lupus, or spondylitis, or now psoriatic arthritis, is totally changed now that we have these biologic drugs. Most of what we do now is deal with prevention, preventing heart disease, cancer, infections, and the like. Patients from the disease standpoint are doing so much better, and yet there are additional problems coming up. What do you see now as the change in the way you deal with the diseases today, say, taking off from the comments that I just made?
My pet peeve is something called the algorithm. Whenever we meet with our pharmaceutical colleagues, they say, "What's your algorithm for treating psoriatic arthritis? What do you do here and there?" And that's what they want to know. And then, not so much the American College of Rheumatology, but you are the European organization, always comes out with guidelines. I haven't seen an issue of Annals of Rheumatic Disease where there's not a guideline for treating any one of the 150 diseases or disorders that we look at. And then you have to realize, my God, that's from 40 European countries, and some drugs are available in Denmark and not in the Czech Republic. And guess what? Some of this is political, where people choose one treatment over the other. And guess what? Some of these treatments are going to be obsolete in 3 years, and some are not affordable, and some require, let's say, advanced equipment such as MRIs that aren't available. And I'm being bombarded with algorithms. And what's even worse is that when I want to give a patient a intervention that I feel would be appropriate, then the carrier calls me up and says, well, our algorithm is that you have to try A, B, and C first. And you're talking to a nurse or a secretary who has no medical experience explaining to them why they can't have some of the other agents. I think the problem is we're losing our interference, and if we do want to practice the preventive medicine you're talking about, the guidelines are really very annoying, and some people are actually burning out and leaving medicine because it's difficult to sort all this out.
Well, Swami, what do you think? What do you think about this? I mean, the patients coming in now, their diseases are much better controlled because of what you have at hand to use. And how are you facing the inevitable problems with the multiplicity of treatment options, like Dan just mentioned, which creates its own area, and also the side effects and the other internal medicine issues that come up because of the use of biologics?
Yeah, Michael, it's a great question. I think obviously change is inevitable, and we are in a changing environment. Some of the issues that were to the fore in the past have now alleviated, and new problems have occurred. We're now seeing more infectious complications, for example. We've also become extremely aware that cardiovascular disease is an important comorbidity that we need to focus on as rheumatologists. So those sorts of trends have become established practice now as we move forward. What I have found is that the complexity of illnesses has multiplied, and we're certainly seeing a lot more people who don't fit the typical phenotype that we have read about in textbooks. And, going back to my fellowship and early career, one of my favorite quotes was when you said that rheumatology is a contact sport. You got to get in there and talk to the pathologist, the radiologist, the pulmonologist, the critical care person, and really get in contact with them and try to figure out these complex problems. So that's a good approach, I think, that will help young rheumatologists, and hopefully will continue to solve these complex problems. As you know, rheumatology is still considered one of those fields where people call us when they can't figure things out. So I'm hoping that we keep that spirit and we keep building on it.
What do you think about this information overload that we're getting today? Every day, I don't know how many computer messages I get about updates, tips, study results, new ideas, what happened. Yesterday, I was at the FDA on the advisory committee for a drug that's being that's being proposed to the committee to use in scleroderma lung disease. While I was on the committee listening to the discussion, the colleague next to me showed me her cell phone where she got a message that summarized in living time the exact comments that we were making at the FDA advisory committee. She said, "Look at this, Michael. It's all done." Okay, so that was just the most extreme example of information overload that's occurring simultaneously. How do you guys, and you're busy, I mean, you have to deal with this day to day, constantly, morning and night. How do you deal with this information overload?
I get 50 different websites, and at the bottom of them, if you don't want to get any more, I just click unsubscribe, and I pick the 10 or so that I really like. My wife has like 40,000 messages. I really pick and choose and make sure that I make it sane for myself.
Yeah, I think like everything else, it can get overwhelming. But I think the fix is really to spend some time to prioritize which information sources you trust and which ones you actually want to hear from. You use tools like unsubscribe, or you can use an aggregator service, which only hand selects those journals that you're interested in keeping an eye on, or that particular disease category that you're really most interested in. I use an aggregator service that feeds
Spam filters.
Yeah, I am very careful about accepting invitations for some of the commercially curated talks and things like that come via my inbox. So I think you need to spend some time to manage what information sources you are going to respond to and interact with. And in that context, I think going to trusted sources like ACR and Up to Date and a few other sources that I find the information I need. And then at some point you turn it all off, and you leave the electronic device where it should be, which is not in your hand.
All right. Well, I like those two solutions. One is to unsubscribe, and the other is to unsubscribe in a thoughtful way, trying to filter through all this different material. It's just very difficult for me to see how to sort through the quality of the information that you're getting. What do you both of you still read? Go to primary sources when there's a problem? Do you call colleagues around the country? What do you do when you're stumped clinically?
We're very lucky because we're in a very enriched environment with a lot of knowledgeable individuals. As I travel around, I find that a lot of rheumatologists in underserved areas are information starved, and they see 80 people a day and have 3 or 4 nurse practitioners, and when they get a hard case, they need thought leaders who they can call, and they're not always easily or readily available. And I think it's a regional thing, Michael. I think depending on the specific dynamic of the environment that your workplace is in dictates what you're going to do.
Yeah, I think so. So when I'm stuck, I usually will, try to get to some primary source articles and see if there's any guidance in the literature. And I will definitely pick up the phone and call a colleague, and sometimes it's across the nation. And I find most rheumatologists, even a lot of the senior rheumatologists, are very generous in explaining things, or giving you a quick opinion, or pushing you in the right direction, so that you might be able to help your patient. So I find that collegiality among rheumatologists is quite extensive and continues to be alive and well. And I definitely look to that sort of relationships. I think our professional groups like American College of Rheumatology, going to the annual meeting, using that as a networking opportunity to say hello to people who've been good to you and have helped you. And I think that those are important aspects that rheumatologists should engage in.
One of the things I've noticed is that there's a lot more diversity among rheumatology. They come from all over the world, and a lot of them are from cultural backgrounds where they don't question and don't network as much, or they're scared to, or they're easily intimidated. And I think it's part of the training programs to help ease that.
Let's expand this a little bit with probably should be our last question, and I want to know your serious personal opinions about this. The anecdote goes something like this. I had a chance to talk to a colleague of mine at the Mayo Clinic. The Mayo Clinic gets a lot of people sent there because the patients are not satisfied with the care they're getting by their rheumatologist at home. And what my colleague told me was that at least 50% of the time, the care in terms of controlling the disease was totally adequate. The right decisions were made. But at the same time, the patient's pain was not being addressed, and the patients felt that they were not in control of their situation, and they continued to be unsatisfied with the care they were giving, in spite of the fact that objectively the disease was in remission, for example. And my colleague told me that most of the time, of this 50%, the problem is the communication between that patient and the local doctor. And that level of communication then presented itself as the patient needing another opinion, when in fact the disease in question was being adequately controlled, but the patient was not doing well. And the funny thing about the anecdote is the patient would go back to the referring physician and then still be unhappy and step calling the Mayo Clinic for additional help because the patient felt that the Mayo Clinic doctor was more understanding of their real concerns. All right, so you understand what the dilemma is there. How do you deal with this? What's your way of avoiding this kind of situation?
One way you can deal with this is, and it's more depersonalized in larger health plans, let's say Kaiser, is to send out a survey to the patients after the visit saying, did your doctor address all your concerns? And you don't even have to have them identify themselves, but just ask general questions of the nature, were you satisfied with the diagnosis, with the care, with the time the doctor spent with you? I know Kaiser does this. And then that's often in that particular health setting, I've known of several doctors who were not reappointed or whose contract was not renewed because they did not address it. So in a larger health plan, this can be done. However, the problem is in more underserved areas, which is literally half the country, you can't get in to see anybody for 6 months. You can't fill out that type of a survey. And I think the problem has to be attacked more in the first and second year of medical school when you do a physical diagnosis and learn the exam. I think it has to be addressed at an earlier level in order to be successfully managed.
I agree with what's being said. I think some other tips on this issue that I may be able to add is I think listening to what the patient's concerns are. And, for rheumatologists, the field itself is unfortunately, we deal with a lot of uncertainty. And I let my patients know in these situations that I am uncertain, for example, about their diagnosis. But, if they are getting better, highlighting those areas that they're getting better on. And also being open to obtaining second opinions. And we're, lucky that we live in an area where that's possible. And as Dan pointed out, that may not be possible everywhere. But I think being open to that sort of looking over what you're doing is good, and the patients themselves feel more comfortable that you're doing your best. And I think the crux of the matter, as you pointed out, Dan, and you alluded to, Michael, is communication. I think if we are, I teach our trainees the value of communicating what they're doing to their patients, then a lot of those second opinion consults of patients seeking out the Mayo Clinic, etc., may be unnecessary, as you pointed out in the case.
Well, patient-reported outcomes are becoming a much more important tool in managing patients today and, for example, deciding which drugs go on the market. Do you think that's a corollary of what you're talking about?
I think so. I think patient-reported outcomes and self-assessment outcomes and frankly, measures of quality, both of your care itself, but also of your processes that you and your clinic employ. Those are all areas that are not only going to be important, but actually going to be mandated, because as you know, the whole trend is to pay for quality rather than pay for volume. And that's a necessary thing that will allow the healthcare system to sustain itself. And I think all rheumatologists and all practitioners of medicine have to be educated in measurement of outcomes and learn how to incorporate these outcome measurements into their clinical practice. Dan Solomon in Rheumatology has led some of these studies of using outcomes and treat to target and bringing that into the clinic, and he's written a really amazing chapter along with his fellow in this particular issue of rheumatology clinics, which I would put a plug in for anybody who's interested in learning how to implement these outcome measures in their own practices.
All right, gentlemen, I think you've done a great job in addressing what a starting rheumatologist looking out into the future will be facing, what some of the problems are, and even some of the solutions, so that they go in with their eyes wide open.
Thank you for joining us for this edition of the Clinics Review Articles podcast. For an exclusive discount on the issue we discussed today, focusing on best practices and challenges to the practice of rheumatology, visit us.elsevierhealth.com/expert. Rheumatic Disease Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the podcast on the iTunes and Google Play stores.